guys.
Good morning.
Good morning. We're the last sitting session before lunch, okay? And then we're going to get up and moving. So we're going to get you guys going. My name's Jordan. I am the Structural and CV Heart Coordinator at Methodist Willowbrook. Where's all my Willowbrook people? Yes. I've been at Methodist for 8 years, nurse for 10. I'm a ICU cath lab nurse. So that's my background. Nice to meet you guys.
Good morning, everyone. My name is Courtney Shaw. I'm the Structural Heart Nurse Navigator, also over heart failure at Houston Methodist The Woodlands. I've been with Methodist for about 6 years.
All right, my name is Liz Golden. I'm a RN3 on 6 South at Houston Methodist The Woodlands, and I've been with Methodist about 5 years.
All right.
When y'all were checking in, you were given some badge buddies. Those badge buddies are going to be a resource for you all, kind of pertaining to the things that we're going to be talking about. So we'll go through some quick learning objectives. Our objectives are going to be understanding cardiac registries, analyzing discharge medications, recognizing importance of early follow-up and patient education, discharge principles. We're going to highlight follow-up and support in heart failure, emphasize heart failure and self-management instructions, and best practices in AFib discharge planning.
And just like that, you're experts. We can go, right?
Yes.
Okay.
So what is the ACC? What is a registry? The ACC is the American College of Cardiology. Registries are databases that we put patient data points into to see what our outcomes look like. It's also based on evidence-based practice.
And we're sharing it with you all today.
Yeah.
These are all of the cardiac registries that are in the ACC. Many of them we do participate in at Houston Methodist across the system. So we're going to talk about some of them that a lot of the communities participate in.
All right, I'm going to talk briefly about public reporting. So that is clinical and procedural information that's collected by registries or health systems that's made available to the public, which includes patients, providers, policymakers, and payers, to promote transparency and to help consumers make informed healthcare decisions. Public reporting reinforces accountability and aligns organizations with evidence-based cardiac guidelines. And then shared decision-making. The ACC and the NCDR and CMS mandates that physicians thoroughly document and actively involve patients in their care treatment plans and decisions through shared decision-making tools. So that kind of explains the risks, benefits, and alternatives. And this improves trust and long-term adherence to treatment plans. And then sorry. They talked earlier about this, but we'll just go over briefly the New York Heart Association classes, class 1 through 4. 1 being no limitation, 4 being unable to carry on any physical activity, and this just quickly communicates functional status and guides therapy for heart failure.
All right, I'm going to go into heart failure. I know we've talked a little bit about it this morning, but what is heart failure? So it is when your heart is not pumping adequately. One of the big things that we want to focus on for you all is while patients are in the hospital, the nursing management behind that. 2 of the big factors are daily weights and strict INOs. Next slide. Guideline-directed medical therapy is extremely important as well. So for patients that have an EF less than 40%, we want to make sure that we're putting them on an ACE, ARB, ARNI. Of course, that's if their kidneys can tolerate these things. We want them on a beta blocker, and then if they can, go on a SGLT2. Those are Farxiga and Jardiance. Those are ones that we don't see as often, but are seeing them more frequently. Some of the discharge instructions that we want to focus on is lifestyle changes. So we are all very common, heart failure patients are everywhere. A lot of times they are non-compliant, so we are constantly reiterating to them, please eat a healthy diet, make sure you take your weight in the morning, make sure that you're limiting your fluids, always kind of reiterating to them that these things will make them feel better and have better quality of life. Next slide. Follow-up appointments are extremely important in these patients. They're very sick. They usually have multiple comorbidities. They frequently come back to the hospital. If we can get the patient scheduled in an appointment before 14 days with preferably their primary cardiologist, if not with a primary care doctor, so that they can make sure that the patients are staying on track. This helps patients stay out of the hospital as well as have a better quality of life. We are going to do a poll everywhere with this presentation to kind of interact with you all. So this is one of our patient scenarios. You have an 80-year-old female patient that's a lifelong smoker. She lives on the 3rd floor of a private apartment. She comes to the emergency room with severe shortness of breath. Respiratory rate is 40, oxygen is 89. Her pulse is 175 beats per minute, and her blood pressure is 90/50. The patient is diagnosed with acute reduced heart failure after an echocardiogram. So we'll pull up the poll everywhere if you'll text DeBakey to that number.
Yeah, and we're going to be doing this throughout the presentation to keep you guys with us. So we'll give you just a few minutes here to get this going. We'll give you till like 10:18.
So what medications are you going to ensure provided at discharge? This is a select all that apply. A beta blocker, an ACE inhibitor, an ARB, an ARNI, or all of the above.
Okay. Is everybody good to go? Yes? No?
I think if you go to the next one, we'll like do that. Nobody?
There we go.
Okay.
Okay, so we need to focus on this a little bit more. The answer is all of the above.
Oh.
This patient,
Yeah.
oh, there we go. Good job.
All right. Okay, friends. We are now going to talk about cath PCI, my friend, my favorite here. How many cath lab nurses are in the room? Woo! Okay. How many of y'all have taken care of a patient that's either post-MI or got a stent? That should be like this whole room, right? Okay. As we all know, heart disease is one of the #1 killers of Americans, right? It's rampant, especially in Houston. We have seen at Willowbrook alone our PCI volume skyrocket year after year after year after year. Volumes are only increasing. So I think this is super, super important. And I want to talk to you today about the difference between cath PCI and chest pain MI or NSTEMIs, okay? And how it pertains to our registry. Every single patient that goes to the cath lab and gets a stent goes into a national registry, okay? So we monitor metrics on all of these patients to say if we're doing what we're supposed to be doing, right? Are we discharging these patients on the proper meds? And we'll kind of talk about why that is so important, okay? But essentially, a cath PCI can also cross into an NSTEMI. So a patient with elevated troponins, these are usually your patients that are coming through the ED. They had chest pain at home. They had chest pain a couple of days ago. They're going to be coming to us mainly on an on an inpatient setting. They're either in-house or they're coming through the emergency room, and they have elevated troponins. Okay. So those patients fall into that chest pain MI category on the screen. On the opposite side, we have the cath PCI. These can be outpatients. They had a positive stress test with their cardiologist. They go to the cath lab. We find a blockage. We put in a stent, right? So these patients, though, can intertwine because a NSTEMI is probably going to get a stent, right? So that patient is going to cross over into 2 cardiac registries. So this is just high-level review of all the things and the differences between them. But big thing, chest pain, STEMI, NSTEMI, those are a chest pain registry. If they got a stent, they're going into our PCI registry, okay? Following? Okay, so how do we decide what these patients discharge on? It's not just Dr. Kunapuli wants to discharge the patient on these meds, right? We have guidelines, and so the American College of Cardiology and the American Heart Association work together to create these guidelines, and these come out every few years. So we have guidelines for valve disease, we have guidelines for hypertension, we have guidelines for PCI, for chest pain, and we use these guidelines and these flow sheets to direct our care, right? What we're gonna do with the patient, what they're gonna go home on, what they're gonna look like after they leave us. So key things, early follow-up is key with all of our cardiac patients, right? We want these patients seen typically within a week, whether they're heart failure or a chest pain patient. We're gonna medication optimize them, and I'll get into that a little further. And then we're gonna risk factor their management, and we're referring all these patients to cardiac rehab, which is also one of my best friends that we'll talk about in a bit. Okay, so here are the medications that every single one of your patients should be going home on. It's okay, you don't have to remember this. We gave you badge buddies, right? So when you're discharging your next PCI patient and you're unsure of what meds they're supposed to be going on, you're gonna look at that badge buddy and you're gonna be like, oh, I am missing a P2Y12. And we're gonna be getting the doctors on the phone and figuring out why this patient isn't going home with a P2Y12, okay? P2Y12, I'm stressing the most on because that's my best friend. I always tell my patients when we're discharging them, if you got a stent and you are on a P2Y12, so this is your Plavix, Brilinta, Effient, they are swimming to the pharmacy when Houston floods, okay? We are not missing a dose of that P2Y12 because a stent is a foreign object in the body. If that stent closes, AKA you're not taking your P2Y12, you're gonna have a heart attack and you're gonna be coming back to see us. So big thing when you're discharging these patients that have a stent, do not forget that P2Y12. If you take anything away from today, make sure your patient has a P2Y12, okay? Fun fact, Plavix is actually, or clopidogrel, you see that name a lot. A lot of the population actually doesn't tolerate that medication. It's a CPY40 medication, but essentially part of the population does not respond to Plavix. So at Willowbrook, we're discharging a lot more of our patients on Brilinta and Effient. So you may start to see that as a trend. We've just found that Plavix isn't as effective, but it's very cheap. So take away there. Okay. How we decide how long somebody's gonna stay on DAPT. DAPT is dual antiplatelet. So a P2Y12 and aspirin is the most common, okay? There's a whole algorithm on how long we decide a patient's gonna stay on this medication, but big takeaway, if they were an NSTEMI or a STEMI, or even had a stent as an outpatient, you're usually gonna send this patient home on DAPT for 1 year. Okay, that's what the guidelines recommend. Now, if they're very high risk for bleeding, like we've talked about, then we can shorten that to 3 months as the current guidelines state, but 3 months for high risk bleed, 1 year for everybody else, okay? Lastly, our good old friend metabolic syndrome here, right? We all know the hypertension, diabetes, obesity. All these patients are the main patients that we're gonna be seeing with these factors, and so we want to take into consideration their nutrition and psychological factors when we tailor our discharge education. Last thing kind of with PCI here is just common discharge restrictions. Please remind these patients if they went to the cath lab, okay, that when you're discharging, no driving for 2 days. That's not because of the stent itself, it's because of the access. We accessed an artery. Arteries bleed. We don't want them to bleed while they're driving and hurt people, right, or themselves. So no driving for 2 days, no lifting anything heavier than 10 pounds. Avoid stairs if it was a groin access, okay? And then again, what are we doing with this P2Y12, guys? We're swimming to the pharmacy, right? We're not missing a dose of that medication. Super, super important. I don't think we stress it enough to these patients. And then they're gonna be following up with their cardiologist as well. So here's our case scenario. We got a 64-year-old man. He's admitted with an anterior STEMI. He undergoes a PCI of his LAD. His echo shows an EF of 35%. He is discharged with aspirin, or P2Y12 Tigrelor, atorvastatin, and metoprolol. What additional medication should be added related to that reduced EF? We have furosemide, lisinopril, warfarin, or diltiazem. Good job, good job. The correct answer is lisinopril. It's an ACE or an ARB, okay? So you could look at your little badge buddy there and see what we missed, but we're gonna be adding lisinopril to this patient's meds, or we should be questioning the physician of why we're not sending him home on that. Last question. 70-year-old man undergoes elective PCI for angina with a 90% RCA lesion. It was treated with a drug-eluting stent. He has no contraindications to exercise and an uncomplicated hospital course. According to the registry, which additional component should be added at discharge? Is it referral to cardiac rehab within 2 weeks, prescription for a dual antiplatelet therapy for 1 month, documentation of cardiac rehab referral, or a routine stress test within 30 days? It's kind of a trick question. I'll give you that one. The correct answer is C. You guys got it right. It's we're gonna send that patient to cardiac rehab. Okay.
Okay, and now I'm going to be talking about CABG and STS. So as y'all know, whenever patients get PCIs, sometimes they end up getting a CABG, or sometimes their level of disease is so severe that they have to go straight for the CABG. So I'm going to be going over those guidelines. The guideline-directed medical therapy, just to go over really quickly, antiplatelet therapy, that's lifelong aspirin, the PY12 inhibitor if indicated, usually if they have a prior stent or if it was an off-pump CABG, and then beta blocker, high-intensity statin, ACE inhibitor, diabetes medication if applicable, and then diuretics, usually short-term. Sorry, that's okay. And just to kind of wrap up, like a lot of these medications are started in the hospital after the procedure, and they must be optimized prior to discharge to set up the patient for success at home. And then discharge instructions, heart healthy diet, limiting alcohol, gradually increasing the activity, no lifting over 10 pounds, no driving for 4 to 6 weeks until cleared by CV surgeon. And then, of course, incision care is very important, making sure they know the signs and symptoms of infection, no tub soaking. Structured discharge education decreases readmissions, and it improves recovery confidence in our patients. All right, and then follow-up appointments, also very important, especially the first 4 weeks after surgery. They're gonna be seeing the CV surgeon, cardiologist. Cardiac rehab is incredibly important for these patients, and their primary care doctor. And they kind of just work as an interdisciplinary team to make sure that these patients are getting everything they need at home and being successful at home. Okay, so we have another question / scenario. So 62-year-old male recovering from triple vessel CABG performed 5 days ago. Hospital course was uncomplicated and he's preparing for discharge. Incision is healing well. Okay, did y'all read everything? Let me see, sorry. I'll read it to you, I have it here. So he was prescribed beta blockers, aspirin, statins, and diabetes medications. He reports mild fatigue, chest pain, no chest pain, lives with spouse, and plans to return to light activities. So which are the top 3 priority teaching points you would include in the discharge education? A, proper incision care and signs of infection, importance of gradually increasing activity, how to monitor blood sugar levels, returning to driving within 3 days, understanding medication purpose, or resuming smoking. Which obviously you're not gonna do. All right. A, B, and E. A, B, and E are the priority. The diabetes is also, of course, important, but whenever you're talking about the discharge teaching specific to CABG, A, B, and E are the top ones. Okay. And then I'm also going to talk about AFib management, because as you know, that's a common post-op arrhythmia. Just to quickly go over paroxysmal and persistent. So paroxysmal is the short lasting, less than 7 days, usually resolves within 24 to 48 hours. Normally stress induced, and then persistent is the one that does not go away, requires treatment to stop, and lasts for more than 7 days, and often needs medication or intervention. And then the guideline-directed medical therapy for that really highlights stroke prevention with anticoagulants, rate control with beta blockers, calcium channel blockers, rhythm control with antiarrhythmics or electrical cardioversion or ablation if necessary, and then risk factor management, for blood pressure, diabetes, weight, sleep apnea, avoiding alcohol, and then the procedural options, which are the ablations, the LAAO, which Courtney will go into a little bit later. And just a couple things to keep in mind to make sure that whenever people get prescribed medications for AFib, they require regular blood work, potentially EKGs, INRs, and a lot of these need to be started in the hospital to see if they're safe for the patient. And then discharge instructions for AFib, taking medications as prescribed at the right time, at the right way, in the right dose, watching for symptoms such as chest pain, palpitations, dizziness, resuming light activity, not strenuous, and then following up with cardiology to get any scheduled testing such as the EKG, INR, and then limiting the alcohol, caffeine, quit smoking, heart healthy diet, all those good things. And then we have another one. Yes. 68-year-old male is being discharged after being hospitalized for new onset AFib. He's stable on metoprolol and Eliquis. Heart rate is controlled and he reports feeling better. He asks what he should watch out for at home and when he can resume his normal activities. So which discharge instructions are appropriate for this patient? Taking Eliquis daily without missing doses, return to heavy lifting, call doctor for dizziness, palpitations, follow up with cardiology, or drink alcohol freely since heart rate is now controlled. And it is all select all that apply.
Or select all that apply.
Yes. All right. What about A? Yeah. So the correct answers are A, C, and D, which y'all are doing great.
All right, so let's just talk about AFib. We're going to lead it into left atrial appendage occlusion. So whenever patients have AFib, they're obviously going to be put on anticoagulant. That times is not able for patients to tolerate. They may have GI bleeds, other issues. So getting a left atrial appendage occlusion device is something that can allow these patients to come off of those blood thinners because this will seal and then be able to protect them from having a stroke. So guideline-directed medical therapy for it. It is a little bit different depending on the device that is implanted, but for a Watchman device, it is 45 days, and then after an amulet, it's 90 days. They usually almost always will still continue to take baby aspirin for life. Of course, these things are different, indicated by the physician that's doing these things. Discharge instructions, so very common to some of the other things that we're talking about, not driving for a couple of days, avoiding heavy lifting, incision care. This is done in the cath lab via heart cath. Taking the medications, just like Jordan was really stressing, is telling these patients you have to take this. We can't go without, we've got to get you to the mark of where this device is completely sealed and you're not at a risk for a stroke. Dentist visits are extremely important with these patients because they have a device now. Typically, they will get prophylactic antibiotics for it, so making sure that they understand, hey, if you're going to the dentist, having some work done, and or getting your teeth cleaned, you need to talk to your doctor and make sure that you're getting something ahead of time. Some potential problems after having a procedure like this can be an increased heart rate. Typically, the patients are in and out of the cath lab same day, but you do want to make sure that you're looking out for any signs of potential complication. Of course, you want them to look out for any signs of a stroke also after this because they're going to be having this get sealed off. Next slide. Follow-up appointments with these procedures are extremely important. This is based on evidence, so this is what the registry also requires for us to have the patients do after they have this device. So they follow up in the clinic 2 weeks after the procedure with the physician, and then at 45 days they have another TEE completed so that the doctor can go in there and see if that seal is complete. If that seal is complete at that time, then the patient can come off of the medications. That's what every patient's intended purpose is for this. So having that follow-up timely is extremely important. Most of them want the device put in and off of the medications the same day, but they have to get that TEE to make sure that it's sealed. With other devices, it is a TEE at 90 days, and then these patients are followed within the registry for 4 years. We track for 2 years. So at 6 months, they have to come back and see the physician, at a year and 2 years. So they are followed very closely for a very extended length of time. So we'll do another poll everywhere. You have a 70-year-old female patient with non-valvular atrial fibrillation, recently underwent a left atrial appendage occlusion procedure to reduce her risk of stroke. She has a history of prior GI bleed. Like I said, most of the time is why they're getting this. While on anticoagulation, the procedure was uncomplicated. She's preparing to discharge on aspirin and apixaban for the next 45 days. Which of the following are key discharge instructions for this patient? Continue the medications, follow up with a TEE, resume high-impact exercise within 7 days, monitor for signs of bleeding, report any unusual bruising or black stools, skip follow-up imaging since the LAAO eliminates the need for any further testing, avoid heavy lifting and strenuous activity until cleared, or understand that stroke risk is not completely eliminated and follow-up care is essential.
Select 3. Good job.
Y'all are doing a great job. That is one of the biggest things that need to be stressed to these patients, that just because you got a left atrial appendage occlusion device, it does not mean your AFib is going away if you take anything from that.
Okay, guys, last one. Here we go. TAVR.
Fall asleep.
TAVR is a procedure that we've kind of talked about a lot in general in the CV world as it's been newer. It's a minimally invasive aortic valve replacement. Here's just a picture of the valve. If you ever have a patient with aortic stenosis, there you go. If you ever have a patient with aortic stenosis, I like to tell them that the aortic valve is the Mercedes-Benz of their heart, right? Get where I'm going here? It looks like a Mercedes-Benz. So they either have a good Mercedes or a faulty Mercedes that needs to be replaced. And so in this case, the one to the far over here by me is faulty, right? And so there's 2 ways to replace it. We either do open heart surgery or we do a transcatheter valve. Transcatheter valve is really for our elderly population that are high risk for open heart surgery. And so with that procedure, it goes into a registry, right? And we track this registry, we track these patients at 30 days and at 1 year after the procedure, okay? And just like everything, there's certain medications that they need to go on. So here is the regimen for antithrombics post-TAVR. If they had a recent PCI, they're staying on that P2Y12, okay? We're keeping them on that medication, we're not changing it. If they've not had a recent PCI or they have no coronary disease, it is okay to send them on a single antiplatelet. So either a P2Y12 or even just aspirin. So that's very physician dependent. So some of these TAVRs you'll see go on only aspirin, sometimes only a P2Y12, sometimes both. If they're a prior AFib patient like Liz talked to you about, they're gonna go on a DOAC. So this is the model that we use to decide which medication they're gonna discharge on, okay? Again, here's their follow-up appointments. We have to do a 30-day echo, KCCQ, EKG, an office visit, and also document NYHA class on all of these patients. So they have their procedure, they come see us again at 30 days. We make sure that that Mercedes is still working now that they have a new one, and then we bring them back a year later and we check on it again, okay? So that's something that CMS requires us to do. Common discharge restrictions are just like all the other ones. This is an arterial access, right? Just like cath patients. We're pretty strict with them. No driving for a couple of days. We're avoiding heavy exercise or activity in that groin area because we're accessing a 16 French sheath through the groin. It's a big sheath, it's a big hole, so we want that to fully heal. It typically takes 1 week for that groin to heal, okay? So for 1 week, I'm telling these patients, take it easy. Don't be going up and down the stairs. Don't be Valsalvaing on the toilet, please, okay? I've seen it happen, and they have to come back. So we're just taking it easy for 1 1 week, and then we are also enrolling these patients in cardiac rehab, okay? If you're one thing you're gonna learn today about cardiac registries, they're all going to cardiac rehab. That too is on your badge buddy. Here we go. 78-year-old man undergoing a TAVR for AS. He is discharged home on day 3. The site participates in the registry. At 30 days, which of the following data elements are we required to collect? Is it mortality status, hospital readmissions, and patient-reported health status, aka a KCCQ, an echo with valve gradients only, medication adherence and dietary habits, or quality of life questionnaire? What are we doing? Oh my gosh, you guys are so good. You're right, 80%. We're doing all those things. Yes. Okay, and now we're going to kind of wrap up here about cardiac rehab, okay? So cardiac rehab is available at all of the sites across Methodist and even outside of Methodist. Every hospital has a cardiac rehab program. The ones that require, we send these patients are the PCI registry, the chest pain registry, CABGs, right, or open heart surgery patients, even SAVRs or MVRs as well, and then our TAVR patients. So all these patients should be going to cardiac rehab. It's a 36-session program, so the patient gets 36 outpatient sessions. They typically go 2 to 3 days a week for 30 minutes. And I like to tell them, if anybody's had a hip or knee replacement, you have to go to physical therapy after a hip or knee. If you've had a heart attack or one of these procedures, it's physical therapy for the heart. And you're monitored, and you go there to help build back your endurance and your heart strength, okay? So very important when you guys are discharging, we're discharging these patients every day, that we encourage the attendance of cardiac rehab. They now get text messages sent to their phone once they have their procedure complete, and so they're already gonna be getting text messages to sign up, so you might see them asking you a lot of questions about this. All right, a few more things.
So CareSense, what is CareSense? It is a pathway that we have designed for a lot of these CV service line specific procedures or patients that are having things done. We have it for CABG, we have it for surgical valve, TAVI, LAAO, and heart failure. It's daily text messages that are sent to the patients. If they're having a procedure, there's an anchor date. It's whatever date they're having the procedure. A week before, they get a message that says, hey, how are you doing? You're gonna have this procedure. Don't forget to not eat or drink anything after midnight the night before. This helps support the patients. Of course, sometimes it's through email and text messages, but it's all automated. So patients are getting these things before they have procedures and after they have them to continue to support them on their journey of success.
All right, and I'll just quickly go over implant cards. Patients receive these post-procedure for device implants. They need to keep it with them, educate patients to present the card, and inform dentists whenever they have gotten in a device implant. And then it gives MRI compatibility as well. A lot of times, as y'all know, these kind of hang out in the chart, and then sometimes they leave and we don't give it to them. So just make sure we're getting them to the patients, because it's very important for them to keep with them once they've gotten a device implant.
Okay, and then lastly, just to wrap up, here's all of the educational resources available to you guys as Methodist employees. Obviously, we have the Houston Methodist DeBakey CV Education on YouTube. Here's some great apps that I use for patient teaching all the time. So you can download these apps from your phone. They have visuals. You can share these resources with your patients, okay? And then we're gonna end it with a brief video about CardioSmart, and we're gonna go to lunch, okay? CardioSmart is an amazing interactive tool. I don't know if you guys are able to play it back there. Maybe. Here we go. Patient education tool, though. So this you can show your patient like what a stent does, right? How it's going to go in. You can show them ablations on here. There's heart failure resources on here. All the procedures pretty much in the cath lab are on here. You can draw on this app and show them, oh, here was where your blockage was, right? It was in the LAD. So just a really fun interactive app that you can show patients or just use as yourself. And that's everything. Let's go to lunch. Woo!